Group 2's weekly group project will discuss mitral valve stenosis. Group members include Leslie Fernandez, who is responsible for describing what is the disease and the risk factors. Stephanie Hollister outlines diagnostics and patient outcomes. Joseph Eliason is in charge of the final formatting and video presentation. Courtney Holcomb narrates the presentation and introduces the group. Callie Everett discusses treatments. June Garcia outlines the pathophysiology of mitral valve stenosis. Kimberly Thewis develops the case study. Rosalind Domingo describes the complications of the disease if left untreated and the signs and symptoms of the disease. And James Gaynor is responsible for describing the pathogenesis. Our case study includes a 40-year-old female who complains of shortness of breath for 6 months and increasing fatigue, especially after working out. She also experiences periods of rapid fluttering heart rate. Upon examination, her blood pressure is 105/88, heart rate is 95 with heart murmur detected, and she is afebrile. EKG reveals atrial fibrillation, and chest X-ray shows left atrial enlargement. She is allergic to lisinopril, and her past medical history includes hypertension, rheumatic fever, and migraines. The shortness of breath started out as mild with physical exertion to now sometimes even at rest. Fatigue has also gotten worse over time, increasing to the point that the patient has needed to take naps throughout the day. Rapid fluttering heart rate happens at random times, and patient hasn't noticed it with any specific activity or inactivity period. During the exam, patient was asked about a cough, and she said she had been coughing for about the same time period as the shortness of breath with an occasional blood-tinged sputum. Patient has had hypertension for the past 5 years and had strep throat multiple times as a child into early adulthood. As a young adult, she developed rheumatic fever that was not treated immediately. An echo was ordered and later read showing mitral valve stenosis. Mitral valve stenosis is a condition of the heart. The mitral valve that allows blood to flow from the left atrium to the left ventricle does not function properly. This may lead to decreased blood flow from the left atrium to the left ventricle, causing a buildup of blood within the atrium that may cause this atrium to be enlarged, eventually leading to atrial fibrillation or even heart failure in severe conditions. Risk factors for the development of mitral valve stenosis may include a history of rheumatic fever, untreated strep throat infections, or a congenital stenosis of the mitral valve. Rare causes may include a calcium buildup that narrows the mitral valve, Fabry disease, lupus, or radiation treatments. Rheumatic fever may develop if strep throat or scarlet fever is not properly treated. It is an inflammatory disease affecting mostly children. Although it is considered rare in the U.S., this disease still exists in other countries. If rheumatic fever develops, mitral valve stenosis can occur, causing damage to the heart. Mitral valve stenosis is also congenital. It may be present at birth, and if it is, children usually do not live beyond 2 years of age without corrective surgery. If mitral valve stenosis is left untreated, multiple complications may occur. Complications include pulmonary hypertension, right ventricular failure, dysrhythmias such as atrial fibrillation, blood clots, or heart enlargement. This is all caused due to the narrowing of the mitral valve, and due to the narrow valve, it does not open like it should, causing blockage of blood flow to the left ventricle, which reduces oxygen to the lungs. The pathogenesis of mitral valve stenosis can be attributed to acute and recurrent inflammation that produces the typical pathological features of the disease due to rheumatic heart disease. Autoimmune activation of lymphocytes and macrophages lead to inflammatory damage. These include fibrous thickening and calcification of the valve leaflets, and fusion of the commissures, which are the borders where the leaflet meet, and thickening and shortening of the chordae tendineae. According to Lilly, by far the most common underlying cause of mitral valve stenosis is prior rheumatic fever. Approximately 50 to 70% of patients with symptomatic MS provide a history of acute rheumatic fever occurring on average 20 years before presentation. Other rare etiologies of MS include calcification of the mitral annulus that extends onto the leaflets, infective endocarditis with large vegetations that obstruct the valve orifice, and rare congenital stenosis of the valve. Signs and symptoms of mitral valve stenosis may include dyspnea, orthopnea, swollen legs or feet, heart palpitations, fatigue or weakness with increased activity or exercise, chest pain or discomfort, heart murmur, or atrial enlargement. Mitral stenosis is a narrowing of the mitral valve orifice comprised of the mitral valve annulus, anterior and posterior mitral valve leaflets, and anterior-medial and posterolateral papillary muscles. The narrowing or stenosis impedes normal flow of blood from the left atrium to the left ventricle, resulting in increased cardiac workload and decreased cardiac output. Stenosis can be attributed to a variety of causes that would contribute to valvular narrowing and decreased blood flow. Rheumatic MS is due to a delayed complication of acute rheumatic fever. Antibodies to streptococcal antigens cross-react with valvular tissue, in which accumulation leads to valvular damage over a length of time. The hallmark feature of rheumatic MS is the fish mouth appearance of valve orifice due to commissural fusion. Other lesions contributed by rheumatic MS are chordal shortening and fusion, thickening of the valve leaflets, and superimposed calcification seen at later stage of the disease. This is the most common cause of mitral stenosis. Degenerative MS, also known as mitral annular calcification, is typically found in the elderly population and contributed by progressive annular calcification involving the base of the leaflets due to aging. And unlike rheumatic MS, calcification is mostly noted on the tips of the leaflets. Leaflet calcification limits its mobility, resulting in the hallmark feature of an open commissures, unlike the fused commissures seen in rheumatic MS. The calcification is noted to be caseous with a central soft core comprised of calcium, cholesterol, and fatty acids, and a white, caseous, thick toothpaste consistency due to liquefaction necrosis with a surrounding outer calcific shell. This is mostly associated with cardiovascular diseases such as hypertension, atherosclerotic disease, and aortic stenosis. Congenital MS is the least common cause of mitral stenosis, which is mostly diagnosed in utero or shortly after birth due to isolated congenital mitral stenosis or underdeveloped cardiac structures. Signs and symptoms, clinical outcomes, and treatment is dependent on the altered valvular anatomy contributing to stenosis. Inflammatory is due to autoimmunity in response to group A beta hemolytic streptococcal M protein antigens, which leads to inflammation and scarring of the valvular leaflets, contributing to stenosis. Radiation-induced is due to late complication to cumulative dose chest radiation, which leads to calcification of the anterior mitral annulus, unlike in degenerative mitral stenosis, which involves the posterior annulus. Radiation-induced disease involves calcification in other cardiac structures, such as aortic valve and anterior mitral leaflet and thickening, leading to constrictive cardiomyopathy in severe cases. Unlike degenerative mitral stenosis, the absence of commissural lesion and no involvement of subvalvular structures. Diagnosis of mitral valve stenosis begins with the patient's medical history, because the most common cause is rheumatic fever, followed by calcium deposit buildup related to increasing age. Cardiac auscultation is an important step when performing the physical examination because of the presence of any of the following four signs: a pronounced S1, early diastolic opening snap, rumbling diastolic murmur at the apex using the bell, and presystolic accentuation of the murmur. An electrocardiogram and chest X-ray can then be ordered when mitral valve stenosis is suspected, which demonstrate atrial enlargement. Echocardiography provides the definitive diagnosis of mitral valve stenosis. Imaging such as transesophageal echocardiography and cardiac MRI provides more detailed view of the mitral valve. Cardiac catheterization may be performed to assess the severity and treatment implications if the other tests are inconclusive or discordant. Asymptomatic mild to moderate mitral valve stenosis may be left untreated. It is important to establish regularly scheduled appointments with your cardiologist or primary care provider to monitor for the progression of mitral valve stenosis. Tests that monitor the disease include electrocardiogram, MRI of the heart, transesophageal echocardiogram. Symptoms and progression of mitral valve stenosis may be minimized through lifestyle changes. Monitoring diet, exercising regularly, and maintaining a healthy body weight are all controllable factors in patients with mitral valve stenosis. There are no medications that cure or fix mitral valve stenosis. However, there are medications that treat the symptoms and side effects caused by the stenosis. These medications aim to alleviate symptoms by reducing the workload of the heart and maintaining a regular rhythm. Diuretics reduce fluid accumulation in the body to decrease the amount of stress put on the heart to pump extra fluid. Anticoagulants help prevent blood clots. Mitral valve stenosis puts patients at risk for stagnant blood accumulation, which form clots that could be pumped to the lungs or brain, causing pulmonary emboli or stroke. Beta blockers or calcium channel blockers slow heart rate and allow the heart to fill with blood more effectively. Antiarrhythmics to treat atrial fibrillation or other arrhythmias. AFib is the most common arrhythmia associated with mitral valve stenosis, thought to be caused by the increased stress on the heart or infections such as strep. Antibiotics are used when mitral valve stenosis is caused by an infection. Rheumatic fever is caused by strep infection and one of the leading causes of mitral valve stenosis. If conservative methods of monitoring, lifestyle changes, and medications do not control the symptoms of mitral valve stenosis and the patient becomes symptomatic, providers may choose to do percutaneous balloon mitral valve valvuloplasty. During a balloon valvuloplasty, a catheter is guided through an artery to the mitral valve. Once the mitral valve stenosis is located, a balloon is inflated to widen the valve. The widening of the mitral valve relieves the stenosis and improves blood flow, which reduces symptoms associated with mitral valve stenosis. If the stenosis is caused by calcium deposits or scar tissue located within the mitral, a commiserotomy can be done to remove the calcium deposits and scar tissue. This is an open heart surgery. If all the above methods fail to treat or repair mitral valve stenosis, a mitral valve replacement is done. During a mitral valve replacement, the mitral valve is removed and replaced with either a mechanical valve or a biological tissue valve. Patient outcomes depend on prompt diagnosis and treatment of patients with mitral valve stenosis. For worsening symptoms, earlier intervention and treatment can help reduce mortality. Data supports mitral valve repair, when feasible, is associated with better patient outcomes and long-term survival rates compared to replacement. Continued monitoring for the need of mitral valve reoperation is necessary, and lifelong anticoagulation is needed for mechanical valve replacement. For our 40-year-old female patient, conservative treatment options include medical management of AFib and aflutter, lifestyle modifications, and monitoring for worsening symptoms. Percutaneous balloon valvuloplasty was performed due to worsening symptoms not relieved with medical management and patient-reported relief of symptoms. Continued mitral valve monitoring, education, and follow-up is important to assess further need for intervention.